new patient comes in, what's your process? How do you figure out what the problem is and how to work on it?
History.
History, most important. Glad you said that. They won't say it in Latin, but they'll come pretty close. What else? Muscle testing, what else? Pardon me? Range of motion, what else?
Where does it hurt? Where does it hurt?
Symptoms, where else? Those symptoms, everyone forgets about the symptom pattern charts. Try it with showing those to patients. They absolutely love them. I don't know exactly what it is, but they love to be able to see, it's in your book. I have 37. It's, you know, it's a good process, but that's valuable information. What else?
Functional movement.
Functional movement, biomechanics. What else? Orthopedic tests, neurological tests. Has anyone taken the diagnosis course? Has anyone taken SFMA or FMS? SFMA, which is in our diagnosis course, is probably the best system for finding a problem or not missing a problem that's away from where the symptom is. X-ray, blood tests, all those things, they'll all get you pretty close. They'll get you to shoulder when I go like that. And that's where we're going to go to work. We're going to take that diagnostic process and we're going to not only get it down to a structure, but if you do it correctly, you're going to narrow it down to the structures that is the root cause. Everyone talks about working the cause instead of the result, but it doesn't always happen. And if you do this, it's only 3 steps, and if you do it well, you'll be at the source. There's a couple of advantages for working on the source of the problem first. The biggest advantage is if you work on the source of the problem, more than half the time, the rest of the problems go away. They're done. And that saves you a lot of work, but it also confirms that you found the source of the problem. And then the third effect of that is the patient thinks you're really smart because you fixed it and it probably wasn't where the pain was. How did you know that? And that's not a bad thing either. So 3 steps. Everyone messes up the first step, including me. So don't be a rookie. Don't mess up the first step. Show me the position or motion that causes the problem. I didn't say pain. If you say pain, they're going to limit their answer to what hurts. Maybe the problem isn't what hurts, because it doesn't move. And then the second step is, in the first step, show me the position or motion that causes the problem. And then let's say it's motion like that. I'm going to palpate it in that motion. Tell them, do it very slowly and tell me when you feel the problem. Very slowly and tell me. You should feel the problem before they tell you. Just before they tell you. It's a hint that you're on the right track. What everyone messes up is everyone jumps up on the most obvious thing. When you find that most obvious thing that jumps out at you, put your hand on it and keep looking. Do the motion again. And I'm gonna find something that happens before what my fingers are on. And then when you find that, put your fingers on that and keep looking until you've looked all the way around it, front, back, left, right, above, below, in an expanding radius around there, and nothing is happening wrong. So you may have to go real far or maybe real little distance, but when nothing is happening before what's on your fingers on, then you found the first aberrant thing that happens, and that's step 1. Step 2, differentiate it. In the level 2 classes, we give you a lot of the steps. It's the first 3 steps of a level 2 protocol is to differentiate the tissues. And basically what you have to do is isolate. I have a problem right here. What could be the problem?
Bicep.
What is right here? Biceps? What else? Pardon me? Pec minor, what else? Cocobrachialis, what else? Pardon me?
AC joint.
AC joint, what else? Supraspinatus, what else? It's funny, but everyone misses the most obvious one. Deltoid.
Yeah, deltoid.
We always look for the hardest thing. What else? Subclavius, what else?
Coracocubicular ligament.
Pardon me?
Coracocubicular
I'm
ligament.
glad you said that. That's the one nobody thinks of. The trapezoid and the conoid ligament. Okay, what else?
Capsule.
Capsule, what else?
Sciatic nerve.
Bone. What else?
Labrum.
Labrum. The point is, there's a lot of things. So what you want to do is lock everything in place and only move one at a time. So you have to be kind of clever, but that's what you're going to do in order to find out exactly which one it is. Then the third step is probably the easiest one. Once you find that aberrant thing, fix it. That's the easy part. Once you fix it, texture, tension, movement, function, then go back to step one and have them do the motion again. It's legal in most states for them to have two problems. So what usually happens is they go a little farther. It's way better. I feel it right at the end. Do step one again. And you keep going, step 1, 2, 3, 1, 2, 3, until they say nothing's wrong and you say nothing's wrong. Then you're done. Okay? But don't be a little stubborn. Be very thorough. Keep going through the process until nothing's there. Okay? So, since we're doing lower extremity, let's say, who has a hip problem? Okay? What's the problem?
I don't know.
Perfect.
I'm some pain in the posterior part of my head.
Okay.
Yeah. And I
Okay.
think it's affecting me.
Okay. Can I use you as a volunteer? Let me use this table. Okay.
You guys can come around and walk.
How'd the problem start?
I'm not sure. I think I'm possibly just finishing it a little bit. My internal rotation sucks and my ankle was so I'm not sure how it started.
Okay. Show me the position or motion that causes the problem.
Honestly, hip extension.
Okay.
Hip extension causes a problem. And I do a lot of deep squatting with patients, just didn't know, so just squatting, getting the pinch in the hip.
Okay. Which one's worse? Hip extension or squatting?
Squatting.
Okay. Most patients will demonstrate just like she did. So that's our test. Squatting is going to be our test. And we need to go through this process until squatting is perfect. Okay? So the first step is I want to palpate during the squat. Okay? You can use me or the table to stabilize, but I'm going to try to palpate everything. Do it very slowly and tell me when you feel it.
Right here.
Okay? Come back up. Okay, I felt something here first, here second. This I felt first. Go again. So now I've got my fingers on what I think is first.
Here.
Okay, come back up. Go back down. That side joint's moving a little aberrantly, but it's still after. Go ahead. Now I got something before this. Did you feel that first?
I did. I felt it.
Yeah, this is first. Okay, but come back up. We only have about 100 or more of these to do.
All right,
so-
no worries.
Okay, now this is first. Here. Okay, go again. Okay, now I'm feeling the opposite side too. Okay, back up. Keep telling me when you feel it.
Here.
Yes, it's still this side. You feel it here or in here?
I feel it where your hand is. Now, when I get down low.
Before, where did you feel it?
Before I felt it in the side.
Right here?
Yep.
Come back.
I feel it here.
Yeah, this is definitely first. Back down.
Here.
Okay, back up. Again.
Here.
Okay, let's go a little slower.
Here.
This is first. You feel that?
That's why my ankle sucked. Yeah.
Yeah, but that's happening before this does.
Yeah, okay.
Go again. Back up. Go again. Okay, go again. Okay. At the same time that happens, and actually the second thing that happens is your whole body shifts this way.
Okay. So what's that?
And that's why you're using that adductor magnus too hard. Is you're taking the weight off your ankle.
Okay.
And that's why all this is happening second. But in the foot is where the problem is. You haven't gone over in foot and ankle yet, right? You have. Yeah. Including
All the
tarsal.
ligaments, not that,
What ligaments?
tarsals? No.
The diagnostic process on the ankle.
We haven't done the diagnostic process on ankles, but we have gone over all the ankle ligaments.
Yeah, okay, but not the process.
No, we haven't.
That's a good time to do this.
Perfect. I was thinking what you're thinking.
Well, let borrow, yeah.
Have a seat.
Get my face in here.
She has a problem right in here someplace. This is locking up and jamming. And then she moves and uses the adductor and puts the weight on the right leg because this doesn't move correctly. And it's right in here that's the problem. Actually, sit here, face that way. You sit with the arch facing away from me because the angles are easier this way. So what I need to do is, actually let's do this first. Just relax your foot and don't help me, I'm gonna move your foot up. Okay, you can see that this externally rotates right away, okay? And it's not so much a twist, if anything it supinates, but it's a huge rotation. So there's an imbalance between the posterior talar ligaments. Which one is short if the ankle goes this way? The outside or the inside? Which was short?
Outside.
The inside. Okay? So that you can tell the heel goes towards the malleolus. So that ligament's short. And this one's long. So they're asymmetrical in their tension. So I need to balance that out. Scoot this way a little bit. Okay, so what I'm gonna do is put my fingers on the posterior tibial-talar ligament. You can feel how quickly that tightens up. And I'm gonna force dorsiflexion, but I'm gonna internally rotate too. And supinate a little, or pronate a little. You can feel that tension.
Yeah.
They're usually contractures rather than adhesions, so you have to hold it for a while. And it's usually 10 to 30 seconds. And usually the patient can feel it let go. It's just starting to let go now. Now see, it speeds up. Feel it give way.
Yeah.
What's the sensation you're feeling on that?
Are you talking to me?
Yeah,
Oh, okay,
like
cool.
a
So once he
burning.
first started, you could tell it tightened up and it was kind of painful, but now as the further we go, it's loosening up and it's getting more dorsal. It's starting to relax so that I can actually.
I tell the patient, you should feel it letting go. You know, so I narrated it for you.
Yeah.
And that's too good to take back for patients, but I tell them to feel like it melts. It just slowly gives way. But you see how different that is.
Yeah.
See, now it's not rotating at all. Okay, scoot back down a little. That's good. Okay. So now I need to know if there's proper extension and pronation supination in all the tarsals. And they'll always flex better than they extend, so it's a judgment call. You don't have any extension between the first metatarsal and the medial cuneiform. Feel that's nothing. It doesn't extend at all. And surprisingly, it supinates, the cuneiforms pronate and supinate really well. No extension between the medial cuneiform and the navicular, well, slightly, but it does extend between the navicular and the talus. But there's the real stuckest part, okay? So what I'm gonna do is I'm gonna put my thumb right on the joint line between the first met and the medial cuneiform. Wiggle my thumb so I don't have an extensor tendon or muscle underneath my thumb because it'll pinch against the bone and hurt. Now I'm gonna keep the ankle in this position of dorsiflexion and push right through the joint. Is that sore?
A little bit, but it's fine. Do what you need to do. It's
Okay, you
cool.
tell me if it's too much, okay?
Okay.
Okay, and we're gonna hold it and wait for it to let go. This one's letting go a little faster. It's surprising how hard you have to push on these. See how my arm is straight? That's why I sat over here, because I can lean onto this. And I'm a scrawny weakling, so I have to do this to be able to hold that much pressure for a while. Who said true?
He did.
Good job, yo.
T-O-N-Y.
Guess you just got nudged under the
There it
bus.
goes.
Yeah.
It was stubborn. It was really stubborn, but it kind of let go all of a sudden. Now, the way myofibroblasts work, as you know, they let go slowly and they contract slowly. If I adjust it, I can block pain, but I haven't changed anything. That's one reason we have to adjust things 3 times a week for the rest of their life. It's because we don't give it time to really let go. Okay, so now you have normal. Let's go back to step 1.
I don't feel that hip pain until I get lower, and I can actually get lower.
And you didn't shift and you went much farther down.
Yeah.
Sure did.
Okay. So she says it's okay, right? What does she know? She's only Okay, go ahead. Yeah,
Feel it here. Yep.
it's all gone.
Yeah.
And the ankle's moving well.
So much better.
Yeah.
So much.
Wasn't that easy? But you can see, if you went by symptoms, you'd never fix this. You'd be working on it forever. You can also see how important your palpation skills are. And I'm going to suggest to you, there's no end to learning palpation. The best way to learn is every patient you see, identify more structures than you need to work. Find a smaller and smaller nerve. Identify everything around there, every little muscle, fascial, tendon, nerve structure in there. Identify them all with your hands. It doesn't take much more time. It's hard to do mentally. It's a lot of work all day long. If you do that with every patient, in 2 months, your palpation skills go through the roof. And you'll make it look easy.
So from here, when she was doing her squat, leaning across barely on her front toe,
Yeah.
what will she do to stay like that? Like what does she need to do?
What happens now?
Right.
I need to check it at least once more. So I would have her do everything she wants to do, work, all those things, push it, and as a good test, and let's check step 1, 2, 3 again, specifically these things, but see if everything's moving correctly. Okay, I suspect that you won't have a problem, just by the way it let go and how complete the change there was. And I also tell the patient, don't be afraid to really use it. It's better to use it, you don't have to protect. You want to use it.
One of the greatest, I know Dr. Leahy for a few days or so, but one of the greatest tips he ever gave me, and I'm sure a lot of other people, he says less is more sometimes. So like in this case, I think even I think we've all done this as a new practitioner, we start from the hips and work everything for 30 minutes. And most of the time they're gonna feel better, but you see Dr. Leahy just doing his assessment, he's done in a few minutes, and he didn't do that much, but yet,
The assessment took more time than the
yeah,
actual
I mean, it's
treatment.
just, so that's one thing that I would commonly say if some people tell me they're doing 20 minutes of ART on their whole lower extremity, I say really see if you can find out what the problem is. And that's what I always say. Dr. Leahy says sometimes less is more. And just, yeah. So
But
I think-
also, there's nothing wrong with just working everything that you find. There's nothing wrong with that.
Two questions. One, what amount of time would you put between appointments? And then, if you're a chiropractor, would you also adjust it?
I see a patient every 15 minutes.
If you want a quick turnaround, like go out and do something and then come back later today, or see you
Oh,
tomorrow?
that depends. On this patient, what would I do?
Yeah.
Like in this situation, I'd have you work out, do everything you can, see you in 2-3 days.
And would there be anything to adjust for this?
That's a good question. Is there anything to adjust? The SI joint that was stuck is now moving.
Okay.
The ankle is completely moving. The knee is moving correctly and the hip is moving correctly. There's nothing left to adjust, which happens. The place it doesn't happen as often is the spine. You very often still have to adjust the spine. I haven't figured out a way to get my thumb on the anterior disc. I should say that, yes, I have, but the worst one, or some people say the best one on palpation, what you can actually get to. We had the people bring in the patients that they can't fix into the seminars, and we use them as cases. And I swear, people, the project that all these guys have is to stump Leahy. But they brought in somebody who'd been in a car accident. They were driving a little Volkswagen or a Mini or something, and it was in Illinois, and it was a steep down on-ramp to a freeway, and he stopped at the bottom of the hill because there was traffic, and a garbage truck hit him. And his seat snapped, and his spine, the seat snapped halfway up, and it went like this, and his spine went 120 degrees, wrapped around the seat and fractured the spine. So they brought him in. He didn't say so, but he was suicidal. If this didn't work, he was going to kill himself. And they had done everything, actually did everything really well. And they said, fix him. But he was, his eyes were, he had, tears, and he was just really, really a lot of pain. So I sat him, and they kind of carried him in because he couldn't walk very well. And he could sit though. And I started working on the back, diagnostic algorithm, and they had fixed everything on the back of the spine. They'd done really well. There was nothing back there. So I figured, okay, it's on the front of the spine. So without thinking, I never would have done it if I realized where it was going to end up. But I had to lay on the side, started down here, and I narrated this thing. Okay, now we're going to start on the lower part of the psoas and the autonomic chain. Let's push the iliac vein and artery out of the way and get behind that. Okay, there's where the psoas, there's the femoral nerve, there's the genital femoral nerve, and I'm going to go superior, and I started working up here, and I'm saying, okay, there's the renal arteries. I'm going to go over the renal arteries and then back onto the psoas, and there's the crus of the diaphragm crossing the psoas, and I'm going to separate the crus of the diaphragm from the abdominal aorta. There's the hepatic vessels. I'm going to go behind those and then back into the abdominal aorta and the crus of the diaphragm onto the spine, and then above the diaphragm. Now I'm behind the lungs, but I could tell from the tension on the tissue I was getting closer and closer to where the problem is. And the problem was the pericardium and the lungs, everything it's stuck to the front of the spine where the fracture was. And so I just worked my hand in between the lungs and behind the heart, and I got to where the fracture was. You could tell everything was just scarred right there. So I had the three guys arch him back the way the accident was, and I separated the heart and the lungs from the scarring on the front of the spine, and just worked it all loose until he got all the way back, and then came back out. Everything was gone. All the pain was gone. I left the room. I had to take a walk. I was so, it was very upsetting. It was hard, for everybody. So it took me about a half an hour, 45 minutes to calm down, but the best part of it was I took everyone to an instructor's dinner that night, and they're telling the story, we're all joking, and it says, yeah, we knew any minute he was gonna pull out a chicken liver. You know? The point though is, think of it as, I don't know where the limit is on what you can feel and find if you take the time to push yourself and learn. And it's worth doing, because that's the most important thing you can do, is find it with your hands. Long story for that, sorry about the long story.
So we're gonna do mesothelium?
Wow. Talk about taking salvation to the next level.
I wish it was for lunch. Good place to take a break?